Good evening, everyone, and welcome to today's wonderful evening with Dr. Murali Bharadwaz. The NEETPG may be rescheduled towards the end of the July or start of the August, we don't know. But for those belonging to the next batch, NEETPG, INACT, and FMG, totally there are 50,000 high-yield facts that you should master. At least 10,000 PYQs of NEETPG and 6,500 PYQs of FMG, another 6,000 PYQs of INACT of the last 10 years, you should invariably practice. So once you do that, every day I will come and deliver at least an hour of session to inspire you. Monday to Thursday will be a particular subject, and Friday, Saturday will be a subject-wise mock test and discussion, and every Sunday full-scale grand test and discussion. And all these PDFs will be made available on the Learner Graph for you to download. Totally, I'll give you 155 PDF ebooks made available on the learnergraph.com. And most important, how you consume the content is very important. Whether you go for any coaching program or video library app or anything, you should consume, you should get that interest, you should have a schedule, and you should prepare. And the job of a teacher, more than teaching, is to inspire you to study every day by becoming your classmate, roommate, benchmate, tablemate, and studymate. So, shuru karenge? Yes. Can the online students can punch? Is the voice loud and clear for all of you, doctor? Please punch. Is the font size fine for all of you? Or do I need to increase the font size? So nowadays, teaching is very easy because PDFs, no need of underlining or anything. We can do a rapid revision. So these are all single liners. There are totally 4,000 anatomy tweets which will be made available in the PDF for you to do the revision. And I'm basically doing the revision through that. So these tweets are the short single liner high yield facts that you need to master by heart. Remember, revise for the tomorrow's exam, based on which the MCQs are created in the actual exam. Now, what is the first functional organ in the vertebrate embryos? It is the heart. The heart beats spontaneously by when? By week 4 of the development. There are 4 chambers in the heart, and the heart beats by week 4. And the heart establishes a left and right polarity by the primary heart tube will loop and establish this left and right polarity. So when will the looping to develop the left-right polarity of the heart begin? Week 4 is what you need to remember. So for this left-right polarity to develop, you require dynein. So any defect in dynein can lead to dextrocardia. Instead of left side, heart's apex will be pointed to right side, which is the feature in cartogenous syndrome is what you should do. Now, if you look at the septation of the atrium, very important. Septum primum grows towards the endocardial cushions and narrows down the ostium primum. And ostium secundum forms in the septum primum due to the cell death, and the ostium primum regress. Septum secundum develops Which side? On the right side or left side of septum primum? Septum secundum develops on the right side of the septum primum, maintaining the right to left shunt. Right to left shunt. Whenever we are in our fetal life, we need to have not left to right, but right to left shunt. Because lungs have not yet opened. Now, how is foramen ovale formed? The septum secundum expands and covers most of the ostium secundum, and it forms the foramen ovale. And in the foramen ovale, how is the blood flow? Is maintained from right to left atrium instead of left to right atrium. Whatever the septum primum that regressed, a small part of it will remain and it forms a one-way valve of the foramen ovale is what you need to remember. So the septum primum will close by abutting to the septum secundum after we are born. What is the driving force for the septum primum to close, for the foramen ovale to close, and the shunt to stop? The moment we are born, as the lungs open up, as the oxygen breathed, alveolar oxygen levels increase, pulmonary vasculature will dilate, vasodilatation of pulmonary vasculature. So the right-sided pressure will come down. So no more right to left shunt can happen. And that will cause the septum primum to close against the septum secundum after the birth is what you need to remember. Very nice to see 16 online classmates, doctor. Very good. JJ Singh rightly says high LA pressure is the one which is responsible. So keep punching some points that come to your mind. That is how you will be very hot and energetic when you are attending this daily live session with Dr. Murali Bharadwaz. 1 hour I will be live, and you can see the schedule. If you look at the below this video, you have the entire schedule of the program, right? Which day what? Monday to Thursday is a subject revision, and Friday, Saturday will be a subject-wise mock test of that particular subject revision. Then every Sunday will be a full-scale grand test and the discussion. So all these PDFs will be made available to you as 155 total PDFs for you to do the revision on the learnograph.com. So when you join our 6-month coaching program, you don't need to buy each of these PDFs on the learnograph.com. You will get all the 155 PDFs to you sent on to your email ID directly by us. So that is what we do. And once 6 months, you are at least try as much regular as you can and then do the revision. If 1 hour I brief you, it should inspire you to do the revision of the PDF for another 4 to 5 hours. If we build that kind of a synergy, atrioventricular synergy, then you will really get the essential sinus rhythm to become the winner in the tomorrow's NEETPG exam, doctor. So, yeah. Now, what is patent foramen ovale? What is patent foramen ovale? You should remember, it is the failure of the septum primum and septum secundum to fuse after the birth leads to patent foramen ovale. Patent foramen ovale can lead to paradoxical emboli whenever there is any atrial septal defect. Now, how is the ventricular septation? It is the muscular part of the interventricular septum that leads to interventricular foramen. The aortopulmonary septum rotates, fuses with the muscular ventricular septum, leading to interventricular foramen. What are the most common congenital cardiac abnormality, doctor, of all? ASD, VSD, PDA, and everything. The most common congenital abnormality is VSD, and VSD occurs in the membranous part of the septum, not the muscular part, is what you have to basically remember. Right, doctor? Now, there are certain conditions where outflow tract formation is affected. So fundamentally, the outflow tract is dependent on what? Neural crest. Neural crest cells migrates and typically they form an aorticopulmonary septum, and that lead to ascending aorta and pulmonary tract. So any neural crest cell migration abnormality can lead to various outflow tract formation abnormalities. What are they? Conotruncal abnormalities. Transposition of great arteries, tetralogy of Fallot, where there is an overriding aorta, persistent truncus arteriosus. What is the basis for all of them? The basis for all of them is the neural crest cell migration is what you need to remember. Now, the various aortic arch abnormalities, one of the favorite questions in exam. You need to remember it like a single liner. First arch, maxillary artery. Second arch, stapedial and hyoid arteries. Third arch, common carotid and proximal part of internal carotid. Fourth arch is the aortic arch on the left side and proximal right subclavian. Sixth arch, there is no fifth arch. Sixth arch is the one that gives rise to pulmonary arteries, and on the left side, ductus arteriosus. You need to mug up these aortic arch derivatives, one of the favorite questions of the exam. Now, what is truncus arteriosus? Ascending aorta and pulmonary trunk form. Bulbus cordis, the smooth part of the left and right ventricles, is bulbus cordis. And what is primitive ventricle? It is the trabeculated part of the left and right ventricles. What is primitive atrium? It is the trabeculated part of the left and right atria. From where does coronary sinus form? Left horn of the sinus venosus. Smooth part of right atrium forms from right horn of the sinus venosus. You need to be very sure about it. Now, what are the various endocardial cushion? What does it contribute? And endocardial cushion defects, what does it lead to? The atrial septum, membranous interventricular septum, AV valve, semilunar valve. These are all formed from the endocardial cushion, is what you need to remember. Now, what are those structures in the fetal life which later become the adult structure? You need to be 100% sure about it, doctor. So, the right common and anterior cardinal vein, right common and anterior cardinal vein, they combine to form SVC. Posterior subcardinal, supracardinal veins, they form IVC. That's what you should remember. Then primitive pulmonary vein. Primitive pulmonary vein typically forms the smooth part of the left atrium. That's what you should remember. Now, few things about fetal circulation. 4 to 5 points, you have to be very sure. The blood in the umbilical vein, what is the oxygen saturation of it is 30 millimeters of mercury, and 80% of the oxygen is saturated. Umbilical arteries compared to umbilical veins, who have a higher oxygen saturation? Umbilical vein has higher oxygen saturation. Umbilical artery has lower saturation, is what you need to remember. Now, in the fetal circulation, there are 3 shunts which will happen. Ductus venosus, it brings all the blood coming from the placenta. It will bypass the liver because of the ductus venosus. Foramen ovale, It is a shunt between right atrium to left atrium. Ductus arteriosus, it is the one which connects the pulmonary artery to aorta. So please don't forget these three shunts in fetal circulation, which is the favorite topic of the examiner. And what is the cause for the ductus arteriosus to be patent when we are in the embryonic phase? Typically, when the lungs are not yet opened in the fetal life, the pulmonary alveolar oxygen levels are low. Any low alveolar hypoxia, low alveolar oxygen tension will lead to pulmonary vasoconstriction, which will increase the fetal pulmonary vascular resistance, and that will cause the pulmonary artery to aorta. Continuously blood will push from high pressure pulmonary artery into low pressure aorta through the ductus arteriosus. So it is the high fetal pulmonary resistance, artery resistance, which causes the shunt through the ductus arteriosus is what you need to remember. So what happens at birth, doctor? We start breathing, the lungs will open up, alveolar hypoxia is no more there, oxygen levels of alveoli surrounding the capillaries of the alveoli, alveolar hypoxia is not there, and that will decrease the pulmonary vascular resistance. And same time, the LA pressure is high, left atrial pressure is high, pulmonary pressure is low, and no more pulmonary to aorta shunt doesn't happen, and the ductus arteriosus will close is what you need to remember. So low pulmonary resistance, high LA pressure is the one that lead to closure of the foramen ovale that forms fossa ovalis is what you need to remember. Then what causes ductus arteriosus to close? Same reason. High oxygen, low prostaglandins close ductus arteriosus, and the ductus arteriosus remnant in the adults is called ligamentum arteriosum. So P for prostaglandins, P for patency of the patent ductus arteriosus. Indomethacin, if you happen to give indomethacin, it inhibits prostaglandin. It inhibits the prostaglandin. And inhibition of the prostaglandin typically leads to the closure of the ductus arteriosus is what you need to basically remember. So which prostaglandins keep the ductus arteriosus patent, doctor? Prostaglandin E1 and E2. Now what are the various fetal postnatal derivatives? You have to be very sure, doctor. Ductus arteriosus is ligamentum arteriosum near left recurrent laryngeal nerve. Ductus venosus in the pediatric life, fetal life. Ductus venosus, it is bypassing the blood from passing through the liver. That become ligamentum venosum. Foramen ovale become fossa ovalis. Allantois, urachus become median umbilical ligament. Umbilical arteries become medial umbilical ligament. Umbilical vein become ligamentum teres hepatis in the falciform ligament is what you need to remember. So all these fetal postnatal derivatives. So what I want to tell you, doctor, is what is a good notes? A good notes is not the one which equips you with lot of detailed knowledge. Impossible. You can't be MS Anatomy, MD Pediatrics, MD Gynops, MD General Medicine, everything in one shot, right? In the short life of 3-4 months or 5 months. How can you become? We have to survive the exam. How do you survive the exam? You need to know that every entrance exam, whenever you go, NEETPG, 10,000 PYQs are there. FMG, 6,500 PYQs. INI CET, another 6,000 PYQs. So what you need to do, you need to quickly go through this entire database of the high yield facts. Don't solve MCQs, just go through the database. So I'll provide to you these PYQs, 10,000 PYQs of NEETPG in the form of 10 sprint ebooks. Go through them. Then you will know, okay, this is what the examiner wants, right? Then once you understood that, every Monday to Thursday, we'll have one subject revision, and I left the schedule below. Every Friday, Saturday, we have one subject-wise mock test. Before only I'll upload the PDF of the question paper and explanatory answers, solve it, check your score, and then join the discussion. Every Sunday, there is a full-scale mock test with 160 clinical vignette-based MCQs and 40 image-based questions. Already 50 full-scale mock test PDFs are lying in the learnograph.com. Another 25 Sundays, I will give you 25 PDFs of the full-scale mock test. Every Sunday, we will have a discussion. So once you do this, every 1 hour I spend with you, if I can inspire you to consume 155 PDFs that I gave by spending another 4 or 5 hours, our combination is going to be the only winning combination in the entire world. I want to tell you. So that is the reason you can give a call to the phone numbers I left below. And today only join for the 6 months NEETPG study plan with Dr. Murali Bharadwaz. So, doctor, what is the most posterior part of the heart? Left atrium. Right ventricle is most anterior part and most commonly injured in trauma. Whenever steering injury is there, the sternum presses back. That lead to right ventricle to get injured. Any left atrial enlargement will occur towards posterior mediastinum. So esophagus can get compressed in the posterior mediastinum, leading to dysphagia. Left recurrent laryngeal nerve can undergo injury and leading to hoarseness, is what you need to remember. Now, if you look at the heart, there is a diaphragmatic surface of the heart. The heart which you see lying on the diaphragm, 2/3 is occupied by the left ventricle, 1/3 is occupied by the right ventricle, is what you should remember. पेरिकार्डियम में कितने लेयर्स होता है? फाइब्रस पेरिकार्डियम, पेरिटल पेरिकार्डियम एंड विसरल पेरिकार्डियम called epicardium. And which one is pericardial space, doctor? Between parietal pericardium and epicardium, that is visceral pericardium, you call it as pericardial space. Pericardium is innervated by the phrenic nerve. Pericarditis will lead to the referred pain to the neck, arms and shoulders, often on the left side. Now, coming to the coronary blood flow, every time the NEETPG examiner's favorite question, right? So, left anterior descending artery, it supplies 2/3 of the interventricular septum. It also supplies the anterior LV. Anterior LV. Saurabh is asking, sir, should I revise notes or solve FMG PYQs only now as FMG is on 6th July? Saurabh, you almost came after the labor pains have started. The expected date of delivery is आगे है. जरा 2-3 महीना हमको टाइम दिए तो कुछ ना कुछ कर सकते. अभी कुछ भी करो काम चलेगा. What makes you comfortable? What makes you to get out of any anxiety? शांति से पढ़ो. जो भी आपको पढ़ना में मजा आ रहा है, right? Don't put too much pressure. By putting pressure, we don't do anything by It's also called widow's artery. Now, posterior descending artery among coronaries, what does it supply? Anterior two-thirds is supplied by the left coronary. So, posterior one-third of the intraventricular septum, posterior two-thirds walls of the ventricles, posteromedial papillary muscles. Papillary muscles are the ones which are holding the mitral valve, tricuspid valve from getting prolapsed backwards. That's the reason any right coronary occlusion can lead to significant bradycardia and heart block. How do you know right coronary MI? Inferior wall MI typically. 2-3 AVF are the leads where you get the ST segment elevation. Right marginal artery supplies the right ventricle. Now, there are two phases, systole, diastole for the heart. Coronary blood flow to the left ventricle and to the interventricular septum. When will it happen? The coronary blood flow typically will increase during early part of diastole, not systole. Early part of diastole is what you need to remember. That's the reason if you give a beta blocker, you decrease the heart rate, you will increase the diastolic filling time. And the more diastolic time is available, the more will be the coronary blood flow is what you need to remember. Now, where is coronary sinus? Between left atrioventricular groove, it runs in the left atrioventricular groove and it drains directly into right atrium is what you need to remember. Now, I should also discuss. When we call coronary circulation dominant, right dominant, if the posterior descending artery arises from the right coronary artery. You call it as left dominant if the posterior descending artery arises from the left circumflex. It happens only in 10%. 90% of our coronary circulation is all right dominant. Please don't forget. You call codominant when the PDA arises from both the LCX and also the RCA is what you need to remember. Now, that is all the cardiovascular, embryology, and a bit of anatomy that you need to know. Now, thyroid. From where does thyroid diverticulum arise, doctor? So we already finished around 66 points we revised within half an hour. Within not even half an hour. 5 minutes pep talk. Right? Pep talk. 25 minutes may 60 points. 150 points high yield facts. Tweets I call them as. 150 tweets we can finish in 1 hour. And there are nearly around 4,000 tweets in the ebook PDF I'm going to give you, which will help you for a rapid revision, right? So every day I revise 200 to 300 tweets with you to inspire you. Monday to Thursday, I'll try to finish at least as much as I can, inspire you on one subject. Same time in the morning, what you do is you sit and finish the revision of the remaining 4,000 tweets and be ready, mark it in the PDF, what you wanted to do, second revision, third revision, which tweets you want to revise and which tweets you want to go back and do a little deeper understanding ke liye revision, right? So ultimately, your preparation should be focused, it should be single-lined, it should be most tested as in the PYQs, right? and it should be within that 50,000 database. 50,000 database of the high yield facts frequently tested by the examiner. Once you do this for 6 months, nobody will stop you to become the winner doctor. So, continuing our journey, thyroid diverticulum, it comes from the floor of the primitive pharynx and descends into the neck. The thyroid is connected to the tongue by thyroglossal duct, and sometimes it can persist as a cyst or a pyramidal lobe, this connection between thyroid and the tongue. It's like Italian mafia in America having, say, connection with the Sicilians and Italians. Now, foramen cecum, it is the remnant of the thyroglossal duct. What is the most common ectopic thyroid tissue site in the tongue? Ectopic thyroid tissue, where do you see it? You see it in the tongue. That's called lingual thyroid. What is the special property of the thyroglossal duct cyst? It presents as an anterior midline neck mass that moves with swallowing, or the protrusion of the tongue is what you need to remember. So, tomorrow I will upload these 4,000 anatomy tweets, ebook PDF on the learnograph.com. If you join our 6 months program, you will get all these 155 PDFs sent to your mail, right? Some of them already done, and some down the line in the next 6 months we will be launching. Otherwise also, you can download by buying each of these PDFs. Now, thyroglossal duct cyst. So basically, the thyroid follicular cells derived, if you look at the thyroid histology, thyroid में follicular, parafollicular cells are there. Follicular cells are derived from endoderm. Parafollicular cells arise from the fourth pharyngeal pouch, is what you need to remember. Now, what are all the hormones produced by the anterpituitary duct? FSH, LH, ACTH, TSH, prolactin, growth hormone, beta endorphin. Intermediate lobe, melanotropin, that is melanocyte stimulating hormone. Anterior pituitary arises from oral ectoderm, that is rat case pouch. And remember, if you look at TSH, LH, FSH, HCG, all the TSH, LH, FSH, and HCG, all their alpha subunits are same. Only their beta subunits determine the hormone specificity, is what you need to remember. Then one more thing you should know. Beta endorphin, the painkiller, melanocyte stimulating hormone, which makes us dark, and ACTH. All the three को एक मातृ माता से पैदा हुए हैं, वो होता है POMC. Pro-opio melanocortin gives rise to beta endorphin, ACTH, and MSH. Then one more thing you should remember. In the pituitary, which hormones arise from the basophils, which arise from the acidophils? FSH, LH, ACTH, TSH. You can remember B flat. Then acidophils. You can remember acid pig. Acidophils secrete prolactin and growth hormone. Then posterior pituitary. Basically, posterior pituitary does not synthesize anything. Everything synthesized, it's called neurohypophysis. Hypophysis means pituitary, right? Neurohypophysis. Because actually it is the neurons in the hypothalamus that produce, and that comes and stored in the posterior pituitary. So it stores and releases ADH and oxytocin, posterior pituitary. And synthesis happens in hypothalamus and transported by neurophycins, is what you should remember. So posterior pituitary comes from neurectoderm, all right, and the anterior pituitary is derived from oral ectoderm. The rat case pouch is what you need to remember. Now, if you look at adrenal cortex is derived from mesoderm, medulla is derived from neural crest. Adrenal medulla is a neural crest derivative. So many times this was asked as a MCQ. Nice to see Motis Kumar, Saurabh, JJ Singh, and many more. Every day I come online, every day I try to inspire you to consume the 155 ebook PDFs that I will give you when you join for our 6 months program for NEETPG, FNG, INI, CET preparation. And 190 hours, I inspire you. I want you to get inspired to consume another 450 to 500 hours in this 6 months period. And that's all, that combination. 190 hours from teacher, 450 hours from you. And हमारा दोनों के बीच में माध्यम है 155 ebook PDFs, which have full-scale mock tests, subject-wise tests, PYQs as single-liners, and tweeters, which have tweets, 4,000, 5,000 tweets about each subject for you to do revision. What more do you need to become a winner? You will automatically become a winner. Only thing is you need to be inspired to do the batting, to do the training, to do the practice every day. It's not just one day. You should not feel tension before exam. You are feeling tension about exam means you have not done well. 6 months you have not done well. It's like a old man in the last moment of the life suffering from involutional depression, saying that मेरा शाम रात नजदीक आ रहा है, मैं डूब रहा हूं, जवानी हो गया बोल के अगर किसी को फीलिंग आए तो वो पूरा जवानी को वेस्ट किया, बर्बाद किया. Similarly, before exam, you should feel confident to raise your head high and go and attack the examiner. That's only possible if you mastered the 50,000 high yield facts, 10,000 PYQs of the NEETPG, along with 75 full-scale mock test practice, of which 25 mock tests we will have discussion on every Sunday, and 50 subject-wise tests in 25 weekends. If you do that, you will automatically become a winner doctor. So today is the day one. We are all way. So I leave the phone number. You can call and enroll today for a highly discounted price, 9000868 Right now, endocrine pancreas. It contains alpha cells, beta cells, and delta. So glucagon, alpha cells, beta cells, insulin, delta is somatostatin. They arise from pancreatic buds is what you need to remember. Now, foregut, midgut, hindgut, right? So from esophagus to the duodenum up to the point of the ampulla of water at the level of the pancreatic duct, and the common bile duct insertion you call ampulla of water. Then lower part of duodenum, third, fourth, and second part after the ampulla of water, up to proximal 2/3 of transverse colon you call midgut, distal 1/3 of the transverse colon up to anal canal above the pectinate line you call hindgut is what you need to remember. Midgut development typically happens in 6th week. There's a physiological herniation which occurred through the umbilical ring by 6th week, and by 10th week it will return back into the abdominal cavity and rotates. 6th, 10th, two important dates you need to know about the midgut development. Now, ventral wall defects. Whenever the rostral fold closure defect is there, you get sternal defect, ectopia cardis. Lateral fold closure defect will lead to omphalocele and gastroscus. Caudal fold closure defect will lead to bladder exotrophy is what you should remember. So what is gastroscus? What is omphalocele? You need to be doubly sure. Gastroscus, there is an extrusion of the abdominal contents. So the abdominal wall defect. It is not covered by peritoneum or amnion. And gastroscus is not associated with any chromosome abnormalities and it carries a good prognosis. Whereas omphalocele is a herniation through the umbilicus, not through any abdominal wall defect, through the umbilicus. Omphalocele is covered by the peritoneum and amnion. Omphalocele is associated with congenital anomalies. Trisomy 13, trisomy 18, Beckwith-Wiedemann, they're all associated with omphalocele. Now, what is congenital umbilical hernia? It is the failure of the umbilical ring to close after the physiological herniation of the midgut, and it is covered by the skin. That is the basis of congenital umbilical hernia. And whenever the baby is crying, a congenital umbilical hernia will protrude with the increased intra-abdominal pressure. Congenital umbilical hernia and other congenital disorders can be associated. Now, what are tracheoesophageal anomalies? So the esophagus got a tritic, and the distal part is of the esophagus is connected with the trachea. Distal tracheoesophageal fistula with the atretic esophagus. That is the most common type of tracheoesophageal anomaly. The moment esophageal atresia is there, the baby cannot be able to swallow, and that lead to polyhydramnios in utero is what you need to remember. The neonates, when they are born with esophageal atresia, how will be the clinical presentation? They drool, drooling saliva, they choke, they vomit their first feeding, and typically the trachea is connected with the distal part of the esophagus continuing into stomach. That's the reason all the tracheal air will go through the distal esophagus into the stomach, and air in stomach is visible on chest x-ray, and there is a cyanosis because of the laryngospasm. That is the hallmark of tracheoesophageal fistula. So how do you know it is there? Typical clinical vignette in NEETPG. Failure to pass the nasogastric tube into the stomach is a indication of the presence of the esophageal atresia. So is it only pure esophageal atresia or whether it is a tracheoesophageal fistula? How do you know? If it's a pure esophageal atresia, the gas cannot go into stomach, so gasless abdomen if you take chest x-ray. Whereas tracheoesophageal fistula, tracheal air is passing to the distal part of the esophagus into the stomach. So that's the reason there will be gas in the stomach if it is tracheoesophageal fistula. So that's how you differentiate pure esophageal atresia from tracheoesophageal fistula is what you need to remember. Now, intestinal atresia. So you have duodenal atresia, jejunal atresia, ileal atresia, any intestinal atresia typically presents with bilious vomiting. Because atresia kahan hota hai? Ampulla of water opening into the duodenum, uske niche hota hai. That's the reason the vomitus that is coming out contain the biliary secretions, because ampulla of water is connecting bile duct into the duodenum. So it is a bilious vomiting in intestinal atresia. Whereas in hypertrophic congenital pyloric stenosis, it is a non-bilious vomiting is what you need to remember. Now, duodenal atresia. It is because of the failure to recanalize. Duodenum should recanalize. X-ray should double bubble. That is dilated stomach with proximal duodenum. And remember, duodenal atresia, D for duodenal atresia, and Down syndrome. Jejunal and ileal atresias, why do they happen? They happen because of the disruption of the mesenteric vessel that lead to ischemic necrosis of the fetal intestine leading to a segment become resolved, and that lead to atresia in the jejunum and ileum. Jejunal and ileal atresias क्या होता है? Triple bubble sign, stomach, duodenum, right? And below that, triple bubble sign, gasless colon, classical of jejunal and ileal atresias. So where do you see jejunal ileal atresias? Maternal smoking, vasoconstrictive drugs, cystic fibrosis, anything can lead to jejunal and ileal atresia is what you should remember. Now, hypertrophic pyloric stenosis. Kaushik Adhikari is asking, sir, is achalasia and atresia are same? Achalasia is lower esophageal sphincter is not ready to relax and it is contracted. That is achalasia, Kaushik. Atresia क्या होता है? Road to block completely. The path itself, गुहा close हो गया. That is atresia. Dinesh is asking, sir, are all classes will be in YouTube? Oh, good question. Yeah, we are commercial, doctor. We are not philanthropic, definitely. But yes, we are commercial with a serious intention, passionate mission to make you get seat. So, 190 hours I discuss, that will not be removed from YouTube. But that doesn't complete revision of all 155 PDFs that I'm going to give you. So you need to consume it. And there is 300 hours of video library of short videos, 5,000 short videos I provide on Score Learning app. That all you get it from when you subscribe to us within the same price. So don't worry, right? Now, but please like this video, share this video, tell all your friends that there is Dr. Murali Bharadwaz who उसको टाइम पास नहीं होता है, रोज ऑनलाइन आता है और रोता है, रोज ऑनलाइन आता है, पढ़ाता है. अगर बच्चों के साथ नहीं मिले तो उनको नींद नहीं आएगा, right? So you tell all your friends, share this YouTube channel to them, and I want to see hundreds of students attending the session every day on the YouTube and enjoy the preparation. And also don't forget to subscribe to our program. We operate at a very, very affordable price to inspire you for about 6 months with 192 videos. We also have a WhatsApp group, Piyush. We have a WhatsApp study groups. Almost we have about 80 study groups and almost 45 to 50,000 students preparing for entrance are there. Purposefully, we didn't go to Telegram channel. WhatsApp is there. So I left the phone number below for you to join our WhatsApp to get the alert when we start the class, 9000-868-356. All right, Doc? Now, so we'll take a 1-minute break with the commercial about our 6 months program. Then I'll rejoin to spend a little more time in this anatomy 4000 tweet revision of the short tweets of single iris. So, welcome back, doctor. Hypertrophic pyloric stenosis, the most common cause of the gastric outlet obstruction in infants. Palpable olive-shaped mass, visible peristaltic waves, non-bilious. Whereas ileal atresia, jejunal atresia, duodenal atresia, they're all bilious projectile vomiting. This is non-bilious projectile vomiting. Hypertrophic pyloric stenosis is more common in firstborn males, and if macrolides, erythromycin-like drugs, if taken, that can lead to hypertrophic pyloric stenosis. And hypertrophic pyloric stenosis, continuous vomiting will lead to dehydration, secondary hyperaldosteronism, leading to hypochloremic metabolic alkalosis. What is that? Hypochloremic. You are vomiting. Hypertrophic pyloric stenosis baby is vomiting what? Acid in stomach. So hypochloremic, that is causing dehydration, leading to secondary hyperaldosteronism. Aldosterone lead to retention of sodium and loss of K plus H plus into urine. That's the reason hypochloremic metabolic alkalosis will occur when hypertrophic pyloric stenosis is there. Ultrasound shows thickened and lengthened pylorus. Treatment is surgical pyloromyotomy. Pancreas. Continuing our discussion. From where is pancreas derived, doctor? Pancreas is derived from the foregut. Ventral pancreatic duct contribute to uncinate process. Both the ventral and dorsal pancreatic duct contribute to head and main duct. What is annular pancreas? When the ventral pancreatic duct is unable to rotate, abnormal rotation, that leads to a ring of pancreatic tissue around the duodenum, leading to the narrowing of the duodenum and vomiting, which is called annular pancreas. What is pancreatic divisum? The ventral and dorsal parts fail to fuse. Mostly they are asymptomatic, but it can cause chronic abdominal pain. Pancreatitis can occur. Coming to the spleen. Spleen arises from the mesentery of the stomach. It is mesodermal. But it has foregut supply. Please remember, spleen has foregut supply, that is celiac trunk and splenic artery. Now, what are all the list of the retroperitoneal structures that you need to remember? Adrenal gland, aorta and IVC, they're all retroperitoneal. Duodenum, second to fourth, not first. Second to fourth. First is intraperitoneal. Pancreas entirely is retroperitoneal, except the tail. Ureters are retroperitoneal. Colon may ascending and descending are retroperitoneal, but transverse colon is intraperitoneal. Whatever. Kidneys are retroperitoneal. Esophagus, thoracic part of it is retroperitoneal. And rectum partially is retroperitoneal. Please don't forget, doctor. Favorite question of the examiner. Now, a few ligaments you should know. Falciform ligament, hepatoduodenal ligament, hepatogastric ligament, gastrocolic ligament, splenorenal ligament. 1, 2 comments about each of them. Falciform ligament. It connects the liver to the anterior abdominal wall. What does it contain? Ligamentum teres hepatis, which is the fetal umbilical vein, and the patent para-umbilical veins are there in the falciform ligament, is what you need to basically remember. Hepatoduodenal ligament. It connects the liver to the duodenum. It contains the portal triad. Proper hepatic artery, portal vein, common bile duct. They're all part of the hepatoduodenal ligament. And it is the part of the lesser omentum. Hepatoduodenal ligament borders the omental foramen of Winslow. We call that one is bordered by hepatoduodenal ligament between the liver and the duodenum. Imagine when you are studying anatomy, surgery, you need to, and gynecology, obstetrics, you need to think you are going into the belly. All surgical subjects, ophthalmology, ENT तो एकदम 3-dimensional thinking रहना है, imagination, right? Hepatoduodenal ligament. It borders the foramen of Winslow. And whenever you are operating, you don't want any bleeding. So Pringles, whenever you apply compression on the hepatoduodenal ligament to avoid excessive bleeding and to control the bleeding. Then hepatogastric, between the liver and stomach, it connects the liver to the lesser curvature of the stomach. It contains the gastric vessels and is a part of the lesser omentum. Gastrocolic ligament, it connects the greater curvature of the stomach to the transverse colon. It contains gastroepiploic arteries and it is the part of the greater omentum. Gastrosplenic ligament, it connects the greater curvature of the stomach to the spleen and it contains short gastric and left gastroepiploic vessels. And it is the part of the greater omentum. Splenorenal ligament between spleen and kidney, which kidney, left pararenal space and the spleen, it connects. It contains the splenic artery, splenic vein, tail of pancreas, and it is the part of the greater omentum. So it's all a question of knowing what to read, what examiner is going to ask, pinpointed specifically, how to recollect, reproduce in the tomorrow's exam, active recall and spaced repetition. Active recall, spaced repetition. If you go to a lot of coaching centers, ultimately what will they do? They will also read the same. Ashtottaram, Suprabhatam. Any teacher, रट्टा मारो, बट्टी मारो, कुछ भी सेशन आप गए, क्रैश कोर्स को गए, कोई दूसरा आदमी आके आपको पढ़ने का जरूरत है क्या? पढ़ाने का जरूरत नहीं है, अपने आप पढ़ सकते. 2-3 फ्रेंड्स के साथ बैठो, राइट? गिव देम, you can share your notes once we give you, no problem. But sit with them, do revision with them. That is how you become better and get the seat. Because you need to internalize into your own body, physiology, into your mind, into your gray cells, and reproduce in the tomorrow's exam, doctor. The job of any teacher is a humble job. There is nothing like a dream team. Understand? Is there any dream team? वो बुक का आता है, वो दिल्ली से आने वाला टीचर, वो मुंबई से आने वाला टीचर आके डांस करे तो ये सब याद रहता क्या? नहीं रहता. अपने आप पढ़ना है, 2-3 साथियों के साथ बैठ के पढ़ना है. I will give you 155 PDFs to you, and I will come every day online. Every Sunday we have a full-scale discussion, mock test discussion with 200 clinical minute-based MCQ, just like NEETPG exam with around 30 to 40 image-based questions. Every Friday, Saturday, we will have a subject-wise test. There is a schedule. I left it below the video for us to have the preparation plan. So once you subscribe with us, I'll give you 155 ebook PDFs, which are there on the Learnograph. I'll give you 300 hours of subscription, 1 year in the Score Learning app, and 190 hours I'll come to inspire your life to self-study around 155 PDFs that I give you. All right, Doc? Now, you should remember that gastrosplenic ligament, it connects the greater curvature of stomach to the spleen. Now, what are the various gut wall layers? Mucosa, submucosa, muscularis externa, and serosa. Mucosa, it contains epithelium, lamina propria, muscularis mucosa. Submucosa, it contains Meissner's plexus. Muscularis externa contain Orbach's plexus. Then there is a serosa, which is the adventitia. So that's what inside to outside of the gut wall layer. So remember, which part of the gut does not have serosa? That's the reason any perforation of that part of the gut will cause quick spread of the gut secretions across the viscera. Esophagus. Esophagus is the only part of the entire GIT that doesn't have a Cirrhosa is what you need to emphatically remember, so many times asked in the entrance exam. Ulcers. Ulcer versus erosion. Erosions are in mucosa only. Ulcer means it will extend into the submucosa, inner layer, outer muscular layer. It can lead to perforation. Erosions don't lead to perforation. Now, gut has a basic electric rhythm. If you look at the frequency, that rhythm is very high in duodenum, basic electric rhythm, BER कहते हैं इसको. Duodenum more than that, more than ileum, more than stomach. That's the order. And who is the pacemaker which is generating this basic electrical rhythm that is needed for the peristalsis? Interstitial cells of Cajole are the ones which are generating this basic electrical rhythm. Now, after each part of the gut, what is their speciality? Esophagus, non-keratinized, stratified squamous epithelium. Upper 1/3 is striated muscle in esophagus. Middle and lower 2/3 is the smooth muscle. Please don't forget. Upper 1/3 is the striated muscle in the esophagus. Coming to stomach, you have gastric glands. They contain parietal cells, chief cells, right? Parietal cells are eosinophilic. Parietal cells produce HCl. Parietal cells produce intrinsic factor is what you should remember. ये चीजों में इतना भी confusion नहीं रहना. इतना थोड़ा confusion है तो 10,000 people will cross you and move forward. Your rank will go behind 10,000. Chief cells are basophilic. Chief cells secrete pepsinogen. Chief cells produce gastric lipase is what you need to remember. Coming to the duodenum. Duodenum has villi, microvilli. They increase the absorptive surface. Duodenum has Brunner's glands. Brunner gland produce the bicarbonate in the submucosa. Brunner's glands in submucosa. Duodenum has crypts of Liberton, which contain the stem cells, which contain the Paneth cells. Coming to the jejunum, jejunum also has villi, crypts of Liberton, plicae circulates. Jejunum has plicae circulates. That's the reason jejunum has a feathered appearance and they will increase the surface area. Ileum has villi, ileum has Peyer's patches. Peyer's patches, lymphoid tissue called Peyer's patches. It is also called mucosa, associated lymphoid tissue. Sometimes it can develop malignancy. That's called mucosa associated lymphoid tissue lymphoma. Maltoma is what you should remember. Ileum has plicae circulates proximally. It has crypts of Liberton. Ileum, if you look at the entire small intestine, the largest number of the goblet cells, where do you see? In the small intestine. Colon has crypts of Liberton with abundant goblet cells, but colon is not involved in absorption except for water. So no villi in colon, which is the differentiating factor, is what you should remember. So इस तरफ हम रोज पढ़ते जाएंगे. Thank you all for attending the day 1 of the 6 months program. Right? I know some of you are still actively preparing for the upcoming NEETPG, upcoming FMG. Don't worry. Enjoy preparation and tell your juniors, always start preparation with PYQs. Then fully 10,000 PYQs, fully mastered 50,000 high yield facts, take enough mock tests to get the practice in the exam conditions. Self-assessment. Nobody need to give you an app. Your rank is 10,000, your rank 20,000. Depression आता है उसको देखे. तो हमको मालूम नहीं होता क्या? हम self correction करना PDF में. I'll send you the PDF. You can take a printout of that and can do the test. No problem. Right? So let's go forward and become better every day. Don't forget to like this video, share this video, comment this video and tell all your friends to come every day to attend the live session with Dr. Murali Bharadwaj.